Thank you, Dr. Case, and thanks again for the organizers for including me in this wonderful meeting. This morning I was asked to speak about persistent fetal vasculature, whether to operate or not. And let me begin with my conclusions. Persistent fetal vasculature was formerly known as persistent hyperplastic primary vitreous, and it is a very wide spectrum of disease. And it represents the most common cause of unilateral congenital cataract. And it was reclassified from PHPV to PFV in that article that I've listed on the bottom by Mort Goldberg. It's 23 years old now, that article, but it is still a very timely article. It is excellent. I think every ophthalmologist should read it because every ophthalmologist will encounter PFV no matter what subspecialty he or she is practicing in. Whether or not to operate for PFV-related cataract depends on the extent of ocular disease, the duration of cataract, and the particular patient's parents as well. Besides vision, sometimes progressive angle closure is an independent indication for surgery. Now that I've given you my conclusions, let me give you my talk. The eye is heavily vascularized before birth, and of course, the vasculature that's in the ocular media has to disappear for the visual axis to be clear. And it's persistence of this abnormal vasculature, persistence of this vascular and ocular media with subsequent contracture of tissue that causes the disease spectrum of persistent fetal vasculature. If it's just in the, just behind the lens, we can get a cataract. If it's in the retina, it can cause folds and detachment. This illustration is from that article I was mentioning before by Mort Goldberg from 23 years ago. And this second illustration from the same article shows the different spectrum of phenotypes we can see depending on where this persistent vasculature, where the fetal vasculature persists inappropriately, ranging from just a little dot on the back of the lens to frank cataract, frank retinal folds, Peters anomaly, really a huge spectrum of disease. Of course, the lens is the most common part of the eye that's associated by persistent fetal vasculature. And this just shows how the lens is so heavily vascularized, this vasculature has to regress, and any degree of its persistence causes the spectrum of persistent fetal vasculature. So when do we operate for unilateral persistent fetal vascular cataract? We operate if the presentation is early. Mr. O'Keefe touched upon some of the challenges we have with unilateral congenital cataract that has a delayed presentation. We operate if the eye is otherwise not grossly malformed. If you have a persistent fetal vasculature that's causing significant retinal folds or detachment, obviously cataract surgery is not going to be helpful. We also have to be careful in these eyes because the anatomy can be dragged, and sometimes retina is in places we don't normally encounter it, abnormally anterior. This third point is a very important point that maybe isn't highlighted enough. We operate for unilateral PFV-related cataract if the parents understand the required amblyopia management. If you have a family that's not going to comply with the amblyopia management, the only thing you're doing by operating for unilateral cataract is giving a risk for aphakic glaucoma. The postoperative management is critical, and if you have a situation where it's not going to be able to be done, you should think twice before taking out that lens. So here's a child with unilateral cataract in the right eye. The right eye is a little bit smaller. This is common in persistent fetal vasculature-related cataract. This is a patient who doesn't otherwise have ocular abnormalities and is fit for surgery. Here's a patient with more extensive. You can see some of the persistent pupillary membrane there. Behind the lens, it's not obvious now, but when the lens is taken out, you can see dragged ciliary processes. This is another characteristic finding we find in persistent fetal vasculature-related cataract. Here's a more angry, aggressive-looking case. Again, it's a huge range of presentation, a huge range of phenotype in these cases. Here's a child who had actually hemorrhage in the plaque. Again, a very large range of presentation in PFV-related cataract. The basic pathology here is the plaque behind the lens. The plaque, sometimes it's just the plaque that's occluding the lens. Other times it invades the lens and there's actually cataract within the lens substance. Progressive angle shallowing can be an independent indication for surgery. Here's a girl who came late. You can see the left eye. It's smaller, as is common in PFV-related cataract. It's really not, there's really no hope for good vision in her, but her angle is getting shallower and shallower because that membrane behind the lens is growing. And if this angle closes, it's a disaster. So if you have progressive shallowing, that in of itself is an indication for surgery, even if you're not looking for a good outcome. Here's another child with the same situation. Not all persistent fetal vasculature requires surgery. Here's a child with anterior persistent fetal vasculature, and it's resulted in pupillary membranes. Again, the vasculature, this illustration shows how anterior to the lens, there's a vasculature that needs to regress, and if its failure to regress can cause membranes that are quite dense in the pupil. Here's a close-up of the same child. This can look pretty bad, but in my experience, they see quite well. It's very rare that you need to intervene in something like this. You don't need much space to have normal development of vision. Here's a child who has a posterior plaque that's not visually significant. And when you can see when we focus on it, there's a plaque. It's been actually compared to this ruby brittle star, an ocean creature, and you can see how it's kind of has a central area, and then there are spikes around it. If we focus more posterior, there's also a stalk going to the disc. This all looks pretty bad, but actually in this child, it's not visually significant. Here's another child, again, with persistent fetal vasculature, not visually significant, the posterior plaque, nasal on the lens, and you can see a stalk on the disc, persistence of the hyaloid artery, failure of regression. Again, this is not visually significant. Just because it's there doesn't mean that it has to be operated on. This was a very interesting case. This child actually had a persistent hyaloid artery and there was actually blood in it. A very unique presentation. Again, not visually significant. We don't need to do anything about this. Again, it just shows the spectrum of PFV. Here's a 7-month-old noted to have white pupil in the right eye since soon after birth. She has PFV, but she also has extensive retinal involvement. Obviously, this is not a surgical candidate. We have to examine the whole eye. PFV can affect the posterior segment as well. So let me go back now to my conclusions, which I started with. PFV is a very wide spectrum of disease, and it's the most common cause of unilateral cataract. Whether or not to operate depends on the extent of ocular involvement, the duration of the cataract, and the patient's parents. Besides vision, sometimes progressive angle closures independent indications for surgery, because if that angle closes, it's a disaster and it's very difficult to deal with, so we can't let that happen. And finally, all ophthalmologists should be familiar with the article I've highlighted below, which is 23 years old, but really defines this and is as timely today as it was when it was written. Thank you.
So
Keith has been
asked to see what my approach to congenital glaucoma is, and just to a few issues. It's rare, it's a difficult condition, it's a chronic condition, and it's a lifelong condition. As you know, prior to development, arrest of the angle, sporadic or autosomal recessive. It's the commonest glaucoma in children, males more than females, bilateral in 75% of cases, and most of them present by 1 year. Usually by about 6 months. There are secondary causes of glaucoma, anterior segment dysgenesis, Peters anomaly, aphakia, which is a huge issue in cataracts in children, aniridia, the phacomatous, and a whole lot of other conditions that give secondary causes. There are systemic causes, metabolic, lows, homocystinuria, the chromosomal disorders, connective tissue disorders, all with secondary causes, systemic causes of glaucoma. And you know the classical features: photophobia, lacrimation, blepharospasm, the big eye, cloudy cornea, eye rubbing, and then the optic disc cupping and the myopic shift. And then the differential diagnosis: cloudy cornea at birth, trauma, forceps, sclerocornea, the dysgenesis, the CHED, congenital endothelial dystrophy, metabolic, the enlarged cornea, and then the watering red eye, which is the other cause of nasolacrimal obstruction, other cause in the cornea, and so on. Examination under anesthesia can be difficult because of the anesthesia, because some of them will artificially lower the pressure. Ketamine is said to be the best option. And so IOP measurements can be a little bit inaccurate, and you can get a low measurement with quite a significant glaucoma. And so examination under anesthesia, you see the edema, the hapstria. There's only, I think, one other condition that gives a hapstria, I think, is forceps delivery. And then the size of the cornea, over 11 millimeters, a newborn suspicious, over 12 millimeters, 1 year probably suspicious. You look at the angle, and you can, classical angle changes. You look at the cup-disc ratio, in a child over 0.5 is very suspicious. And obviously, if you treat them early, and not all of them, some of them you'll get reversal of the cup disc changes. And you do refraction and all the general examination. And this is the classical angle where you have a flat plateau iris hypopigmentation, so a flat iris insertion, and no angle recession, and hypopigmented iris stroma. And the management of glaucoma, obviously, is medical initially, Diamox, topical drops initially until you're ready to do surgery on them. And then, but the main treatment is surgery, and you obviously deal with the angle, either unigoniotomies, trabeculotomy, trabeculectomy, filtering implants, and the other types of treatment are laser as secondary. And obviously, it's very important in these patients to treat the amblyopia, treat the refractive errors, and manage the associated ocular problems. Clergy itself, the type of glaucoma will determine probably your approach, whether the cornea is clear or not, whether it is extremely hazy where you can't see into the eye, determined by the optic nerve damage, whether there's previous surgery being performed, and most important of all is the experience of the surgeon that's looking after this child, and their capability to perform any of these procedures. So surgery is the primary treatment. Goniotomy, it's interesting that Barkin first described goniotomy in 1946. It's so long ago. Noel Rice in Moorfields in London in 86, I think, was described how he had a 90% success rate with goniotomy. And it is a difficult procedure, and it does require experience. And the problem in goniotomy is that we don't do an awful lot of them, and probably residents in training don't get their hands on any of them. So it's something you learn when you become a staff person. So it's not an easy procedure to do. Then obviously in trabeculotomy, trabeculectomy, again, procedures that are not widely done by pediatric ophthalmologists in training. And with the way training has gone now subspecialized, people in residency are not getting to do these type of procedures. Tubes are obviously become very popular in many types of glaucoma, particularly I use them all the time in aphakic glaucoma. And then antimetabolites like mitomycin and 5-FU have become popularized and have been major advantages. And again, of course, don't forget you might have to do cyclodiode in some of these cases. And this is the goniotomy. You do one quadrant, then may have to go back and do a second quadrant. And that's the problem. You need multiple procedures. And then if you have a hazy cornea or a big cornea, it may be difficult to do these type of approaches. And the problem is that you need into multiple goniotomies, and you may get, some people claim, vast success with this. And it has huge advantages, like a good phaco procedure. You spare the conjunctiva, and once it works, it's an absolutely fantastic operation. But if it doesn't work and you're into multiple procedures, you've got to do something else. And we, in '96, we published a long-term follow-up of primary trabeculectomy, because this was frowned upon for infantile glaucoma. But around that time, the use of these mitomycin and all this started to appear. And we had some good success with trabeculectomy. We published a long-term follow-up of these kids afterwards in the ACTA in 2001, again with quite success. So trabeculectomy wasn't to be frowned upon. This is an example of a child with Sturge-Weber. As you know, the risk in these is you can get expulsive hemorrhage. I've done all of these procedures. Mainly, I've done trabeculotomies, trabeculectomies on them, but I've mainly done valves on them. This one such example where the pupil is drawn up, but the pressure is controlled. Trabeculotomy, you open Schlemm's canal, and there's been a lot of new work on it now in terms of even an article on this month's AGO showing some new technique where you can put into the Schlemm's canal and keep it and open it 360 degrees. I just go in and identify Schlemm's canal and use a trabeculotome and go on either side of it and open it up. The problem here is you've got to be able to know how to do a trabeculectomy before you can find a trabeculotomy. And sometimes it can be hard to find Schlemm's canal, particularly in the smaller children. A useful tip, someone else told me, and I always use it, is where white meets blue, Schlemm's canal waits for you. So that's a very useful tip to find Schlemm's canal. And once you go into it, you see the fluid coming through. It's a very gratifying thing to see. What's my final approach to glaucoma? I've gone off goniotomies because in my hands I've had to do multiple goniotomies. They fail. I have not been able to reproduce Noel Rice's 90% success rate. And I think probably the success rate is the same with Pinko and Moorfields. I think you need to do multiple procedures. And my procedure of choice in infantile glaucoma has been to date now trabeculotomy, trabeculectomy. I think it works very well, and it works well as a once-off procedure. So thank you very much.